It's my pleasure to welcome you all on our virtual workshop powered by Volizon Technology. This workshop will cover current topics on IVF and live demonstration on our latest Volizon Shift Plus. Today, we have Dr. Ajay Valia and Dr. Sonal Panchal with us to conduct the session. I would request all the participants to post your questions in the chat box, which will be answered at the end of the sessions. Now, I begin the session with a warm welcome to our esteemed faculty, Dr. Ajay Valia, sir. Sir's area of interest is IVF, ICSI, high-risk pregnancies, operative endoscopy, and advanced sonography. Presented various papers at state and national level. Sir has worked as a member for various committees, FOGSI, like MTP, Infertility. Sir is a chairperson in Imaging Science Committee, FOGSI, from 2000. Dr. Ajay Valia, sir's area of interest is IVF, ICSI, high pregnancies, high-risk pregnancies, operative endoscopy, and advanced sonography. Sir has presented various papers at state and national level, worked as a member of various committees, FOGSI, like MTP, Infertility. Chairperson, Imaging Science Committee, FOGSI, from 2012 to 2014. And Sir is a director of Isha Multispecialty Hospital, Vadodara. Over to you, sir.
Good afternoon, everybody. I thank GE for giving me this platform, and I'll be talking on the 3D ultrasound, the conclusive instrument for detection of uterine anomalies and its classification. 3D ultrasound is the buzzword which is going on. It is very helpful to all the gynecologists. It's getting from my hospital, Isha. And as far as talking about uterine anomalies, the incidence dates back to 1600 century, and in general population it is between 0.1 to 3.5, and in fertile population it is around 4.3%, infertile women it is 3.6%, and sterile group it is 2.4, and recurrent aborters it is very high, it is 5 to 13%. And then talking about uterine duct anomalies, according to ASRM, arcuate uterus is around 32.8%, septate uterus is 33.6% incidence, bicornuate is 20%, and DES is 0.8, unicornuate is 10.8, and uterine diadelphus is 2%. Why it is important? Majority have no problem, but just shift this. Majority of the patients comes with a spontaneous abortions, premature delivery, infertility, abnormal fetal life, cervical incompetence, dystocia at delivery, and dysmenorrhea and endometriosis. Let's start with the embryology. At 6 weeks of gestation, the Mullerian duct, that is paramesonephric, develops lateral to the Wolffian duct. That is mesonephric. The middle and caudal part of the Mullerian duct undergoes medial migration and fusion. The first one-third of the cranial one-third forms the tubes, the middle one-third forms the uterus and cervix, and the caudal one-third forms the upper part of a vagina. So complete formation and differentiation of Mullerian duct reproductive system depends upon completion of the 3 developmental programs as follows: the organogenesis, fusion, and septal resorptions. They're classified into 4 major groups: agenesis of uterus with vagina, like Rokitansky-Kuznetsov syndrome, unilateral
Hi all, there's a small lag in the time. That's a small inconvenience. Sorry for it. We'll be back in a minute. Thank you.
afternoon. Sorry for the interruption. We'll be talking about 3D ultrasound, the conclusive tool for uterine anomalies classification. And 3D, as you know, is a very important tool to diagnosis of uterine anomalies. And greetings from my hospital. The incidence, as far as uterine duct anomalies, according to ASRM, arcuate uterus takes the major bulk of 32.8%, septate is 33.6%, bicornuate is 20%, DES exposure is 0.8%, unicornuate uterus is 10.8%, uterine didelphys is 2%. And majority have no problem conceiving, but have a higher rates of spontaneous abortions, premature deliveries, infertility, abnormal fetal height, cervical incompetence, dystocia at delivery, dysmenorrhea, and endometriosis. Endometriosis and PCOS are many times associated with Mullerian duct anomalies. Talking about embryology, at 6 weeks of gestation, Mullerian duct develops lateral to the Wolffian duct. The middle and caudal parts of the Mullerian ducts undergoes medial migration and fusion. The cranial 1/3 forms the tubes, the middle 1/3 forms the uterus and cervix, and the caudal 1/3 forms the upper part of vagina. Complete formation and differentiation of Mullerian duct into female reproductive system depends upon completion of 3 phases of development as follows. That is organogenesis, fusion, and septal resorption. The sub-classified into 4 major groups are agenesis of uterus and vagina, like Rokitansky-Kushner-Hausdorff syndrome, unilateral development giving unicornuate uterus with or without rudimentary horn, lateral fusion defects, it may be obstructive or non-obstructive, and defects in a vertical fusion, again it can be an obstructive or non-obstructive. ASRM has classified Mullerian duct anomalies into 7 classes, starting from hypoplasia, agenesis to DES drug related. And it has a clinical embryological correlation, like class 1 is a segmental agenesis and hypoplasia causing early developmental failure of Mullerian duct. Class 2 is a unicornuate uterus. It's a complete or partially arrested development of one of the Mullerian ducts. Class 3 is uterine didelphys, complete non-fusion of both Mullerian ducts. Class 4, bicornuate uterus, incomplete fusion. Class 5, septate uterus, complete or partial non-resorption of uterovaginal semen. And arcuate uterus, a near complete resorption of uterovaginal semen. Last is a DES drug-related uterine anomaly. It's a hypoplastic uterus with T-shaped narrow uterine cavity. So ESHRE has its own classification. In a starting, it has an advantage that it is a normal uterus is also added to the classification. The clinically oriented it is, with prognosis correlating to the type of a degree of anatomical deformities. The mode of classification adopted is to sort out classes and subclasses according to the increasing severity. Use of absolute number is avoided in definitions as the uterine size and wall thickness varies from patient to patient. It's talking about percentages of proportions. And cervical vaginal anomalies are classified independently into subclasses. So class UT, internal indentation is more than 50% of uterine wall thickness. That is how the percentages are taken into consideration rather than centimeters or millimeter angles. So imaging modality, let's talk about imaging modalities available in Mullerian anomalies detection. So high resolution 2D probe, it raises first suspicion about anomalies. Sonosaline salpingography is a very important tool, better method than HSgraphy. MRI is a good confirmatory tool for diagnosis, but availability and cost are hindrance for routine use. 3D USG with use of multiplanar, render mode, OmniView, and TUI is a handy and a very useful modalities for diagnosis of congenital uterine malformation. Laparoscopy, hysteroscopy are confirmatory and should be used for offering operative corrective measures rather than just for diagnosis. So how do we approach for the diagnosis? So first, starting important is as we know, history, per speculum, per vaginal examination, because it's very important to find out whether there is any vaginal septum or what are the numbers of cervixes, whether 1 cervix or 2 cervix. Start with 2D USG, preferably transvaginal sonography. It's best seen during secretory phase. Measure size of the uterus. Look for fundal contour, that is outer contour, myometrial thickness and shape of the uterine cavity. When uterus appears smaller in size, especially in height and weight, it can be suggestive of a unicornuate uterus in a normal menstruating female. When fundus appears broad, look for arcuate and septate uterus. On 2D transverse shape or a coronal view, if a cornu appears to taper, move in one direction, look for unicornuate uterus, and if both cornu are seen tapering and diverging, it can be a septate or a bicornuate. While examining the uterus in a transverse coronal scan, if two endometrial cavities are seen, look for a septate or a bicornuate uterus. Now let's talk about different classes of ASRM classifications. So class 1 hypoplasia and agenesis is the findings are absence of cervix and or uterus with a blind ending vagina. In uterine agenesis, no identified uterine tissue is present. And uterine hypoplasia, the endometrial cavity is very small with a reduced intercornual distance less than 2 centimeters. In a unicornuate appears, it's a very small uterus with banana shape. When uterus appears smaller in size, especially in height and width, this can be suggestive of unicornuate uterus. Uterine zonal anatomy is normal. On 2D transverse, if a conua appears to taper or move in one direction, look for a unicornuate uterus. So it can be associated with rudimentary horn and can be observed as a soft tissue mass with isoecogenic, the ecogenicity that of a myometrium. And if it is an obstructed type, a rudimentary horn with a functioning atrium at the endometrium may present as a complex hemorrhage cyst structure. So these are different 3D pictures of a unicornuate uterus. Many times it becomes difficult to find out whether it is a right side or a left side. 2D definitely helps. And especially if it is 3D picture shows like the second one, like this one, second picture, pointing top in the center, it becomes genuinely difficult. In here, the hysteroscopy does help. So OmniView, anyone SSgraphy does help in finding out which side patency is there, YouTube is there. So coming to class 3, class didiphus uterus, it's characterized by two symmetrically wider divergent uterine horns and two cervices. The uterine volume in each duplicated segment is reduced. The two uterine horns are usually wide splayed. 2D is better than 3D in diagnosing this because both are widely splayed, and TA abdominal sonography is always better. So TAs with partially full bladder helps in a better visualization of two separate uteri, and with TVS it becomes very difficult to see both uteri in the one plane, like the following picture is showing. It's a right and left. In the same TVS picture, you won't be able to see. But very rarely in such a transabdominal sonography, you can see this type of two uteri along with the one cervix, two cervixes, sorry. Class 4 bicornuate uterus, there is a partial failure of fusion of ducts resulting in uterus divided into two horns, two uterine cavities with normal endometrium. On 2D transverse, if both the cornua are seen tapering and diverging in opposite direction, it can be septate or a bicornuate uterus. And the most important imaging finding is a concave fundus with a fundal cleft greater than 1 centimeter, as shown by an arrow. An increased intercornual distance more than 4 centimeters is observed. The surface rendering is showing this, and the serosal indentation is also seen here. Coming to septate uterus, it results from the partial or complete failure of resorption of uterovaginal septum after fusion of paramesonephric ducts. A partial septum incomplete involves endometrial canal but not cervix. Incomplete is as it can be called as a subseptate also. A septum is a complete if it extends to either internal or external cervical os, showing two endometrial cavities through the length. The fundus appears broad, and the external uterine fundal contour may be convex, flat, or mildly concave. The indentation less than 1 centimeter is considered as normal. An indentation of uterine cavity is usually in a septum more than 1 centimeter. Acute angle between the uterine cavities, less than 90 degrees. So in a 2D, if we go from below up, we see the diverging uterine endometrial cavity, like the first picture, second and third. And the 3D picture is as shown below. The look over here, the fundal contour, the external fundal contour is normal. So again, here two different uterine cavities are seen, and this is also a septate uterus. There are multiple pictures of septate uterus over here in a 3D. 3D gives a clear view what you are dealing with. Look for the fundal cavity, fundal contour, the external contour. If it is intact, and if you are seeing two different cavities with indentation more than 1 centimeter, think of a septate uterus. So here is a one septate with, again with some shape deformity, but with a pregnancy and one of the endometrial cavities, not one. These are different measurements we can take with the intercornual distance and then the depth from that particular area to the septum, both the cavities when they are joined. There are multiple measures, and according to the measures, one can diagnose whether it is a septate or a bicornuate or a arcuate. We will come to that later. In arcuate uterus, it's a normal fundal contour, no division of uterine horns, angle at the center is more than or equal to 90 degrees. An increase in arcuate uterus is characterized by a mild, smooth indentation of endometrial cavity. The depth of indentation is usually less than 1 centimeter, while that of a septum is usually more than 1 centimeter. Again, here also one sees a broad fundus, increased transverse diameter of uterine cavity. Sonosalpingography also helps over here in distinguishing and finding out the anomalies, and it also helps in telling us about the patency of the tubes. So these are another SS graphic picture showing a typical arcuate uterus. Now coming to class 7, it's an in utero DES exposure. It's a T-shaped uterus. The T-shaped uterine cavity was a known complication of exposure to DES. This type of abnormality is also seen without history of exposure to DES, to DES, because DES is now banned, like in a TB or Asherman syndrome, etc. And it causes recurrent implantation failure, recurrent abortions, preterm deliveries, and the treatment is usually lateral metroplasty with a good results. So Kuhn classification has given certain measures to identify T-shaped uterus, like endometrial cavity is narrow, lateral wall is thick, the lateral depth is more than 7 millimeter, and T angle is less than 40 degrees. So these are different pictures of T-shaped uterus, and that is one on the your left side is the before metroplasty, and one is after the metroplasty, showing a normal endometrial cavity. Now, how do we differentiate between arcuate, septate, and bicornuate? There are different AFS, ASRM, ESHRE, Kuhn, multiple ways to find out, and it always creates a confusion. I'll be coming to it with a simplified method which I follow and I would recommend for everybody. So this particular ASRM is a fundal contour of in endometrial cavity contour. In normal uterus, it is straight or convex. In arcuate, it is with an obtuse angle. In a subseptate, it is with an acute angle. And in a bicornuate, two well-formed uterine cornua with a convex fundal contour is seen. Well, in the same in external contour, when it normal, it is uniformly convex with indentation less than 10 millimeter. In arcuate is also less than 10 millimeter. Subseptate is also less than 10 millimeter. But in a bicornuate, the fundal indentation is more than 10 millimeter. So here it is 3-dimensional surface rendered ultrasound image showing normal outer uterine contour of the uterus that was identified as an arcuate because the fundal indentation appeared as an obtuse angle at the center, less than 1 centimeter dip. A partial septate uterus characterized by normal outer uterine contour, which could be differentiated from arcuate uterus because the fundal indentation was an acute angle at the central point with more than 1 centimeter dip. So the measurements are also taken. So again, there are multiple, as I said, there are multiple ways by which we can diagnose. I'll be coming to resolve certain confusion. Conuta or Kuhn suggestions are also available. ESHRE ESGE established a common working group, Conuta, congenital uterine anomaly. A new classification system is developed by a common working group, Kuhn, congenital uterine malformation, by experts. Objective is to assess the level of agreement between the experts in distinguishing between a septate and normal or arcuate uterus using their subjective judgment. And another aim was to determine the inter-observer reliability. So this is how there are 3 different ways by which they labeled a particular anomaly as a septate, and they have found the last one. Whenever the depth is more than 10 millimeter, it gives the best inter-observer variability and the best results. So again, ISWAG has also done a study and presented papers on differentiating between different ways of identification of septate from bicornuate and uterus. And they have also said, like, the first thing is from ESHRE guidelines. The external, they are talking about external indentation depth is less and internal indentation depth is greater than 50% of uterine wall thickness. Then it is measured above the interosteal or intercornual line. In cum, as I have already mentioned, the depth less than 1 centimeter in external fundal indentation, and while internal fundal indentation is more than 1 centimeter. While ASRM is talking about 1.5 centimeters and angle less than 90 to identify or classify an anomaly as a septate uterus. Again, when we are using different methods, there are chances that we are either over-diagnosing or under-diagnosing and over-treating or over-metroplasties done, surgery done. So there are practical schematic presentations I'll be talking about. It may be a repetition, but this is a normal uterus. It's a convex outer myometrial contour, 10 millimeter dip is allowed. The flat inner fundal myometrial contour, triangular endometrial cavity, and two interstitial portions of fallopian tubes are seen. Arcuate, the dip is 15 millimeter, the internal cavitary dip. In a unicornuate uterus is a small uterus, it's banana shaped. One interstitial portion of fallopian tube is seen with or without rudimentary horn, which may be communicating or non-communicating, usually single surface is seen. In an arcuate uterus convex outer myometrial contour, the dip is 10 millimeter considered normal, and indentation over endometrial contour is more than 90 degrees. In a septate uterus, the convex outer myometrial contour, endometrial indentation is more than 10 millimeter. Indentated inner endometrial contour angle is less than 90 degrees. And there are two endometrial cavities and two interstitial portions of fallopian tubes are seen. In a biconvex uterus, the concave outer myometrial dip is more than 10 millimeter. And indented inner endometrial contour is also more than 10 millimeter. There are again two endometrial cavities and two interstitial portions of fallopian tubes are seen. In a diadelphus, two separate uteri, which are relatively smaller than the normal, often visible in two different planes, better seen in 3D, two endometrial cavities, two interstitial portions of fallopian tubes, and two subapices. Now, this is the final table showing how do we differentiate between arcuate, septate, and biconvex. So, in a normal, the internal contour of fundus straight convex, and external contour is anytime less than the indentation less than 10 millimeter is considered as a normal. So in arcuate, the internal contour of fundus or endometrial cavity is concave and the indentation angle is more than 90. In subseptate, the septum does not extend to cervix and central septal angle is less than 90. In septate, septum extends to cervix, and diadelphus, the two uterine cornua are seen with a fundal indentation more than 10 millimeter. And a unicornuate or rudimentary on a single uterus with single fallopian tube or interostitial opening is seen, and fundal indentation more than 10 millimeter if rudimentary horn is present. So how do we approach practically? Small size of uterus in normal menstruating women, think of unicornuate. With fundal contour normal, up to 10 millimeter dip is considered as normal. Endometrial cavity dip less than 10 millimeter can be unicornuate uterus. Endocavity dip more than 10 millimeter is septate uterus. With fundal cavity dip more than 10 millimeter, along with endometrial cavity dip more than 10 millimeter, it is a biconvex uterus. Unicornuate considered as a normal. Septate operate if indicated. All septate uterus need not be operated, but if repeated abortions are there, one can think of. Biconvex practically not operable, but theoretically yes, it can be operable. And careful examination for vaginal septum and number of cervix are must, and always rule out anomalies associated with uterine anomalies. So what are the advantages of 3D ultrasound? The 3D ultrasound enables the measurement of the length of the uterine septum and depth of the fundal cleft, and it guides us when to operate, when not to operate. And there are different literature which shows also that can differentiate septate, biconvex, arcuate uterus is much better when can eliminate the need of invasive laparoscopic diagnosis. While 2D transvaginal sonography is an excellent screening examination of uterine anomalies, it is not as effective as a 3D ultrasound in distinguishing specific malformations. And they have reported, Jukovic has reported 100% sensitivity and specificity for the 3D ultrasound detection of uterine anomalies in contrast to 100% sensitivity but 95% specificity for 2D ultrasound. MRI has been the gold standard for categorizing uterine anomalies because of 98% to 100% accuracy. MRI can offer additional diagnostic information in patient with equivocal ultrasound findings, but the cost and accessibilities are major hindrance. So in conclusion, there is a high degree of concordance between 3D ultrasound and MRI in the diagnosis of uterine malformation. The relationship between the cavity and the fundus being visualized equally well with both the techniques. 3D ultrasound should be complemented by careful gynecological exploration in order to identify any alterations in the cervix and vagina. So 3D ultrasound offers a number of advantages over traditional diagnostic methods. An increasing body of evidence shows that this technology accurately identifies uterine malformations, more so than 2D ultrasound and other traditional evaluation methods. What's more, 3D ultrasound is a minimal invasive and lack many of the risks and side effects associated with SLC and laparoscopy. Thank you very much.
Hello.
Thank you, sir. Thank you for that wonderful presentation of uterine classification and how 3D has added a help in that. Now, I would like to welcome Dr. Sonal Panchal, ma'am. Our next, where there will be a live section. Dr. Sonal Panchal, madam is a consultant at Dr. Nagori's Institute of Infertility and IVF, professor, Dubrovnik International University, faculty of Van Donald School of Ultrasound, Master Courses, Dubai, National Academic Director, Van Donald School of India, pioneering research work in infertility, PCO-related ultrasound, presented and published paper in national and international conferences and journals, authored and contributed in several book publishing, peer reviewer for our journals. Over to you, ma'am.
Friends, and it's extreme pleasure to talk to you all again, and thanks to G for the same, and for the center, Dr. Ajay Valia, and the entire G team. As Dr. Valia has beautifully demonstrated the role of 3D ultrasound in diagnosis of the congenital uterine anomalies or Mullerian abnormalities, it also has a major role in diagnosing the endometrial pathologies. And of course, we do diagnose these pathologies just by looking at the 2D. We are seeing beautifully the entire cervix here. There's a mucus in the cervix, and we are proceeding towards the endometrium, the endometrial cavity, and we are seeing the endometrium there. I'll try and increase the gains a bit, and we can see a rounded lesion there. The difference in the echogenicity is a bit subtle, and in this cases, it is usually an advantage to use one of the functions of 3D, which is also called VCIA, of 4D ultrasound, which is also called VCIA. When you use VCIA, usually because of the higher thickness, you can much better see the, can we change the settings? Can you put me to penetration, or can you increase the gains here? We can go to TGC and add it. Yeah. So, but I want it in VCI. Just go exit, and put it into VCI. So you can see the polyp there much better, as you are seeing here. We will reduce the angle Can I reduce the angle from there? Okay. So we will reduce the angle, and the other way of doing it is we can switch on to what is a very beautiful mode on this new system, which is called Swift, and that is called Uterine Trace. So we can just go to a 3D mode and we can use Uterine Trace. We would just draw a line with the finger on the endometrium, and we get the coronal section of the, high contrast. Can I move this? And yes, I can see the polyp there. You may have to adjust the gains a bit if the uterus is very deep, and you can beautifully see the polyp over there. You may also do a bit of rotation if you want to. You can move the line up and down and find out where you can see it the best, or you can also use a rotate, which is again from the touch screen, and that can show you the polyp even better. So that was a beautiful polyp demonstration of the polyp there. And we will shift over to the next patient. So that means, okay, we can also probably look at the follicles in this case. And yes, there is one follicle which is pretty large. We can decrease the angle. And you can see with that system, it becomes so very simple to change the gains, to decrease the angle, and also to decrease the, can you decrease the depth for this? And also decrease the depth for the same. When you are seeing a follicle, to measure it correctly, it is essential that you would see it into 2 axes, especially when it is not rounded, and then you can measure. Again, there also we can either use a trackball, or you can actually do measurements with the touch screen. So I'm sorry there, I will have to go to the generic measurements. Can you help me with that? Here. Okay, so I'm sorry, it's not a uterine length, but we will measure, the measurement is going to be the same. The AP, the longitudinal, and the transverse, and the follicular size is 18.7, 15.3, and 11.7. So it's nearly about 15 millimeters, 14, 15 millimeters. If you wish to, we are going to discuss that a little later, but we can also check the blood flows to that. And since it is 15, since it's a dominant follicle, the blood flows have started for that follicle. We will go back to 2D, and we will check the other ovary too. We will have to increase the angle there, and going to the opposite ovary, there are all small follicles. And if at all we wish to, we can just acquire the volume of that ovary, and we will store that for further assessment. Can you decrease the focal zones to 1? Okay, leave it, that will work. Leave it, that will work. And we will acquire a 3D of that. I want to decrease the size of that, and I will acquire the volume. And we will work on that volume a little later when we are changing over with the patients. Can you please store it? Thank you, beta. Sono AVC, of course, requires a bit of post-processing, especially when the ovary is a little deep, as you have seen in this patient, but you can scroll across and find out the follicles that were missing. You can go there and add them or remove them manually. And this is not a follicle, so we'll remove it. Then move on to the other side. Add all the follicles that are remaining. Even if they are small, they can be easily counted. And that tells you the total number of follicles and also the size of the same. Can we go to the report sheet? Yes. So when we go to the report sheet, it shows us all the follicles that were present in the ovary, and it also gives us the size of the ovaries and size of the follicles, and this is the total number, and this is a very important information. It's X diameter, Y diameter, Z diameter, mean diameter. But when the follicles are not absolute round or a good ellipse, they are a bit irregular in size, that's when you may have gross difference in the X, Y, and Z diameters. And in this cases, it is this column which is important, which tells you the diameter based on what is the ultimate volume of the follicle. So this becomes most reliable parameter, especially when you have irregular size, irregular shape of the follicles. So that's how you do Sono AVC. If you have stored that volume of the ovary, are we getting the next patient? So when you have acquired the volume of the ovary, you can also calculate the total the total volume of the ovary, and this can be done by what is called vocal. We will do vocal soon after the next patient, or maybe in the next session of the demo, and we will move over to the next patient. Continues. In the midline, so it's not it doesn't look like a grossly deviated uterus, but when I'm in the midline, I'm seeing the cervix well, I'm not seeing the fundus. As I'm spanning the probe towards the right side, that's when I'm seeing the uterus, and in the longitudinal plane, the uterus looks quite nearly normal. But normally, as we see the mid-sagittal plane, we would always span the probe from one side to the other side, and I'm not seeing any gross abnormality. If I'm rotating the probe towards 90-degree anti-clockwise, I'm seeing the transverse section, and that looks a little too rounded. Even when I'm moving to the fundus, I'm only seeing extension of the endometrial cavity, probably the interstitium on one side. I'm not very happy with that. So we will decrease the angle and we will bring the endometrial cavity right in the center. We might have to go a little more deeper to get a better view of the endometrium. And now when the uterus is slightly deviated onto one side, you always have a doubt whether there's any pathology which is moving the uterus to one of the sides, or it is a congenitally abnormal uterus. And to rule out that, and since we on the transverse section saw only one probable interstitium, we will move the probe on to the other side to exclude the possibility of the bicoordinate or the duplication abnormality. Nothing seen there. On the transverse section, I am moving to the ovary and close to the ileum, close to the iliac vessels. I'm probably not seeing any ovary very clearly there. Maybe it is a little deep, and I can see one. And onto the other side also, it's difficult. There's nothing very close. So let's move and check what is the shape of the uterus and confirm whether it is normal or not. Again, we will go to the same, and that is the uterine trace. And we will, oh, okay. Okay. So she is on endometrial preparation for the frozen transfer. And oh God, that looks like a unicornate uterus. So yeah, you can also do that, and that's an excellent picture that is saved. So that's really a good picture, and you can add a chroma to that. Another thing that you can do is, so this is one way of doing it. The second way of doing it is just taking an acquisition. So you can switch on the 3D and you can acquire, I'm sorry, we don't want to be on this. We can acquire a trace. Do I have a render apart from this, or I just go to render? Oh, okay, so 3D static. And you can, as we routinely do, acquire a volume and then do a render, and that will also give us the almost the same information. You can rotate this image. Okay, I'm sorry. Move out. And that is again the same information that you get. But as you saw, we had to acquire the image, we had to go to render instead. That uterine trace gives us a much better information. So that's with the live cases, and we will shift over to the next presentation, the video session.
Thank you, madam. That was a wonderful demonstration. Now I would like to welcome Mr. Naresh Kaul, segment leader, Volison S&P series and Swift Plus South Asia, to give the product presentation. Over to you, sir.
Good afternoon, everyone, and thanks for joining us on this particular session on ART and IVF and Gynec. I would like to thank Dr. Sonal and Dr. Ajay Valia, sir, for giving us their valuable time and session for this particular education program. And everything what you have seen is very important as far as the clinical aspect is concerned. But same time, it is also important that we should have a very important tool also, which really helps any clinician today to get that kind of output. If you see the legacy of Volison, it has always been that GE is innovating something different every year, and to help these clinicians to get the best diagnosis done in much early stage. So following the same legacy today, I want to introduce you one more family member of Volizon Swift, which is totally different than any other technology what is available in the market today. So let me talk about that particular product, which is Volizon Swift Plus. Okay, so why Bolizon Swift Plus? What we did is we had lots of rounds of research done in number of countries all over the world, and we observed certain facts, and that is what I am going to share with you. So we had more than 250 clinical surveys all across. We did lots of interviews with the doctors and find out lots of things which are really important for them. So what customers said, they said that the present ultrasound systems which are available today are cumbersome. They are really taking time for them to scan, and they are also having some kind of fixed options to offer. Okay, customers also want something more than what we can do on an ultrasound machine. So what we worked on is we worked on some facts, and those facts are based on like simplicity, how we can bring much more simplicity in the machine, how we can make our systems much more efficient, and how we can really work on something which is much more adaptable for them. Just giving ultrasound is not a solution in present situation, but what more we can offer in a package solution which will cater their needs and which can really take care of their problems, that is what we focused on. So that is how this Bolizon Swift came into existence, and this is the solution from us. And can I have the video, please? Yeah, so this is the latest marvel what we are having today with us for all of you to cater the needs what you are having a problematic situation today. It's the Volizon Swift Plus. What we are having in this, so let me take you through some of the important highlights about this particular machine. So what we basically talk about is the simplicity, how this machine is bringing a simplicity in kind of a workflow what we are having. So first and foremost is that you can see very clearly that the number of keys what have been brought into is very less. It's somewhere around 78% less keys with respect to the conventional machines what are available today in the market. You will see clearly that 21.5 touch interface. This is the first in the industry today that this machine is brought into, is totally a touch interface, and we have had a very clear focus towards the areas where a customer wants to work. Not only that, it's very, very familiar for those set of the doctors who are already working on the Volizon series. The workflow will be very simple and will be adaptable as fast as possible. Not only that, you can simply see we have also brought some of the artificial intelligence tools into this, which can really help clinicians to get the best output of any particular image they are looking at in with respect to that of 3D. It's simply attach a tap, pinch, or do a zooming on that. Not only that, it's something like when a smartphone got a revolutionized move towards the new interface, or the same way what we have done is we have got the same interface in the ultrasound. So you can say this is the new smart ultrasound what we have brought for all the users. What we see clearly here is that we can have lots of tutorial videos in this system itself, and not only that, even by just touch of the finger, you can clearly see that you can have menus or sub menus which can really help the user. to have interfacing on the left hand side of the machine on the screen. What more thing we can do is just touch of a button or touch of your finger to the screen. You can see the views from 2D to 3D simply in 2 steps. That's main thing. One more important feature which we have migrated from very higher end machines is the uterine trace, especially when we are looking at the gynec abnormalities as shown by Dr. Sonal and Dr. Ajay V Valia in their presentations and workshop. This is how we can do much faster acquisition of the 3D, and this is how we can work on that. Just a review for that. You have to simply draw a line on the endometrium, and clearly you can see the machine will automatically get a coronal section of the uterus in front of you. So this is what you can see. And not only that, we can also have a slice thickness which can be variable for 1 to 10 mm, and you can also have a uterine guidelines just next to the screen, so that it will be very helpful for any clinicians to compare what kind of the uterus that patient is having, and it will be very, very helpful for the doctor also to decide how we should take it forward. Not only that, we are also having ITA and IDEA guidelines into this particular machine, so that everything is available at particular one point. Now, especially for all those doctors who are really doing ops, we do have a special artificial intelligence features which is dedicated towards CNS screening, that is called Sono CNS. So what customers or what users have to do, they have to simply take a transfer a ventricle plane view, and once it has been acquired by the volume 4D probe, automatically the alignment will be done by the machine as you've seen on the video. Corresponding sections can be adapted, and once you approve them, the machine will automatically take the measurement and will do also the annotations for you. So you don't have to do any more key processes. It will definitely reduce the keystrokes by 78%, which is much more productive for any user to work on. Coming back, lots of the doctors are really having a tough time when they are doing the Dopplers, especially when they have to adjust the gain, they have to adjust the PRF, they have to do lots of things and also focus on lots of other aspects. But here in this machine will automatically help in setting all those parameters by touch of the button. You can just clearly see once a color Doppler switch is turned on, initially the setting is not proper, but just touch of a button, whether you are doing an umbilical artery, you are doing a uterine artery scanning, machine will automatically adjust those corresponding settings so that it is much more user friendly for the customer who is doing it, and definitely it helps you in saving a lot of time. One more important aspect what we have introduced is simplifying when you do a 3D and 4D scan. Many of the machines where you have to do lots of settings, parameters and all, which makes it much more difficult to scan a 3D, 4D scanning. But in this particular machine will automatically adjust the ROI, which is making it much more easier and fast to do a 3D, 4D scan in this particular machine. Now, what more we talk about efficiency. Now, this is the first time in the industry a revolutionized feature has been introduced, which is more towards the anomaly scans. Now today, as you know, we are having Sono NT and IT, which we do on the first trimester scan. Similarly, there are lots of other important measurements which have to be done in the second trimester scan as per the IUSG guidelines. These are the 20 views which are there. We can have a look on that. And all these views will be helped by the machine to the user to get an accurate view, and also we can save these views when a doctor is scanning. So I can just take you through that. Now, just for example, if a view is being screened, a doctor is screening the profile of the fetus. So as he is moving the probe, all those views, once the probe, the image is frozen, the machine will automatically have the annotation of that particular organ. Now you can clearly see from how it is being done. Now you also know that it's not so simple to have accuracy, but as you know, we do have lots of IB, and with that particular IB, we have taken some selected images, more than 750,000 images, which are actually the correct images. So that is the reason there is an accuracy in the artificial intelligence what GE has brought in the form of the features. So this is the Sonal list, which is helping any clinician to have the profile view scanned, viewed, and it can be also stored. Not only that, these views which has been scanned and viewed can be also compared with some of the international selected views, and there will be some test mechanism by which you can see whether this particular image is fitting to the parameters or not. Once the image is identified, whether it has been really selected, it will be it can be approved by the user, or the user can also see whether they can reject it or not. So this is how the machine will help now the user whether the view taken is correct or not. Not only that, we also had lots of other automation tools like Sono AVC Antral and Sono AVC Follicle, which are very, very important, as spoken by Dr. Sonal in the workshop, and definitely we'll be talking more in coming presentations. So the another feature what we have here is Sono Biometry. Presently, we were having 5 measurements which were automatically done, like female length, abdominal circumference, PPD, HL, and HC. But now there are 3 more views which are also helping to take all those measurements which much more faster time. Another latest feature which has been introduced specially for OPS is FHR, which is an automatic fetal heart measurement which will be done by the machine. So what we had to do is we had to just take a cursor on the M line or pulse wave. Machine will automatically set the best parameters of the fetal heart and give you the accurate FHR. That is what machine will do automatically for you. Even there is possibility also, if some user wants to select or reject it, it's up to them. That is also possible. But this is the best parameters which are being approved, and we do have that in this. Not only that, now one more thing which is added into this particular machine is definitely the portability. Lots of places where the IVF and scanning room are 2 different areas to be, you need not to buy multiple machines. With the battery backup, a customer can take this machine from one room to another room, and which makes it much more handy and highly movable. And what is more adaptable, another parameter what we have focused on is lots of the features sometimes are hidden in sub menus and sub menus, so which makes it very complicated for some time to see whether those menus are, and you have to really search. Now what we can do in this machine, we can select the best of the favorites what we are having, whether it is in terms of the probe, or whether in terms of the features, or in terms of the measurements, or other keys whatever we are using. So we can choose from the favorites on this. Not only that, you can have the option of viewing at the different screen. So you can have different options. You can have one option where the screen can be showing 3 different images. You can see on left hand side is small images, main image, and right hand side can be graphs and other things. You can also have an Excel view or a full view viewing possible in this. Many other features additionally to that is definitely some of the frames where, like for example, you can have a color themes available in this, which is something like what lots of the doctors definitely sometimes like a fancy stuff. So we have also introduced them. Not only that, it's really highly mobile, and you can also have this settings as per whether you want to do the scanning on the sitting position, standing, and also you do have variable angles of rotation in this particular unit. We have also brought some revolutionary probes into this, which are latest, especially IC9B, which is focused for the biopsy. And this is something which we definitely want to promote, especially at the places where lots of biopsies are being done, especially in IVF. This is something which is very, very important. One more aspect which we have observed is today you will see many of the machines are loaded with lots of the features, which is somewhat not relevant for some of the specialized doctors, because they do some specialized work. If it is an IVF, if today they are buying a machine, it is loaded with all the features. But what we have done presently in this machine, we have brought into different packages. So what we have done is we have brought 3 different variants, specially focused for the users. Like if a doctor is an MFM, there are selected features which they are using for their screening. If doctor is an OPS, or if doctor is the gynec IVF, the relevant features are given in the package. So doctor has not to spend more on the features which he or she is not going to use. So this is how we have really brought this particular feature set into them. Okay, now Sonalist is also a feature which we have packaged with an OPS, and there are other particular individual variants which a customer can buy optionally. Now, one last thing which I want to talk about how we are adding value here is There are lots of videos which are being fed in the machine, which can help doctors to learn more about this machine. And not only that, we have the first time, as per the FDA guidelines, this is the first machine in which the customer can check the efficiency of a probe. Now, simply connecting the probe and they can really have a test. Multiple times we want to see how the probe is functioning or the machine is tensing. That is also possible. Not only that, a remote team can also check the machine from the remote purpose. So that is how technology we are bringing in more closer to the customer, so that they can really help the services as fast as possible. So this is all from my side about this particular machine. I will request you that if you're interested, please call us to know more about this particular machine, because this is Volizon Swift and this changes everything. Thank you. Thanks a lot.
Thank you for that wonderful presentation of our Volizon Swift Plus. I request all the participants to just share their questions in the chat box, so it will be answered at the end of the sessions. Now, I would like to welcome Dr. Sonal Panchal Madam for the next topic, ultrasound diagnosis of PCOS and what 3D can add. Over to you, Madam.
Thank you, Jin. As she rightly said, ultrasound diagnosis of PCO and what 3D ultrasound can add to it. To start with, what is the role of ultrasound in the diagnosis of PCOS? We who are all working into gynecology and infertility, we do know that PCOS is diagnosed by two of the three features. Please. PCOS can be diagnosed by two of the three features, oligo or anovulation, hyperandrogenism, or polycystic ovaries on ultrasound. That means, of course, there are 4 different phenotypes, but it is polycystic ovaries on ultrasound, which is one of the very important features for the diagnosis of polycystic ovarian syndrome. And how do we define, according to Rotterdam, on ultrasound, what are polycystic ovaries? An ovary which is 10 cc in volume and or has more than 12 ventral follicles is called a PCO ovary, according to the Rotterdam criteria, which were published in 2003. But it was in 2018 that ESHRE ESRM came up with a new amendment for the diagnosis of polycystic ovary on ultrasound, and that said that an ovary must have at least 20 follicles to be called a polycystic ovary. I would correct that, not always 20 follicles, but it is an ovary which is 10 cc in volume and or has 20 follicles. That means an ovary may have 10 cc volume with less than 20 follicles, less than 10 cc volume with more than 20 follicles, and both are polycystic ovaries. So to start with the size, of course, size of the ovary can be easily measured by 3 diameters. Because we have to calculate 10 cc volume, we have to use either 2D 3 diameters to calculate the volume, or we can use a 3D software which is called Vocal to calculate the volume of the ovary. And when we use 3D, it is a much more reliable assessment of the ovarian volume, especially because in all the patients with polycystic ovarian syndrome, it is very, very likely that the ovary may not be a true round or an oval. It is sometimes very longish, and in this cases, taking 3 diameters on 2D may not give you reliable volume assessment. How does this vocal work? You have to first acquire the volume of the ovary, and then you go to volume analysis and select vocal. As you can see here, we have pressed on volume analysis, we have pressed on vocal. And then we can use any of these 4 options to assess the volume or to calculate the volume of the ovary. What is done is the machine, when you switch on vocal, decides to rotate the entire volume 180 degree, and this complete rotation of 180 degree can be finished by either taking a step of rotation of 6 degree, 9 degree, 15 degree, or 30 degree. And usually for the ovary, the volume, the step of the angle is selected as 30 degree. Now, as you start vocal, you would have to draw the circumference of the ovary, which is here seen as a yellow dotted line. And then every time you draw a circumference, you have to press next. And when you do that, the ovary rotates. And with the completion of 6 rotations, you will scoop out the entire ovary, and the machine will calculate the volume of the ovary, as you can see here. So this gives a very precise assessment of the ovarian volume, and this is essential for the diagnosis of polycystic ovaries. The second important thing is the number of antral follicles. As we know, according to the new definition, the number of antral follicles per ovary 20. But I also told you that it can be less than that. A very important study which came up in 2013, and that said that if you get the number of follicles as 26 or more per ovary, in this case, it is a frank manifestation of polycystic ovarian syndrome, and probably, therefore, in these cases, you might not even have to confirm that whether the patient has the other 2 clinical features, the oligoannulation or hyperandrogenism. Generally, and this has a higher sensitivity and specificity than the volume of 10 cc also. Moreover, it is the antral follicle count which is positively associated with the testosterone androstenedione levels and also with the LH-FSH ratio. It is androgen which is responsible for recruitment of the follicles from preantral to antral, and we all know that the PCOS patients have high androgen and therefore they have high number of antral follicles. Females with more severe hormonal derangement may have more follicles. Of course, we all have been trained to count the number of follicles by eyeballing on 2D ultrasound. When you want to do that, you would locate the ovary and thus span the probe across the ovary eyeball and count the number of follicles. Remember, it's very important. You are not going to rotate the probe at all when you are counting the antral follicles. When you rotate the probe, you are going to count the same follicles over and over again. But there are studies which have shown that 2D and 3D are equally reliable modalities to count the number of follicles, as long as the number of follicles are not too many. But if we say that 26 frank manifestation, at least 20 follicles to diagnose a polycystic ovary, it is truly very difficult to count the number of so many follicles correctly just by eyeballing. And that is where you use a software which is called SonoAVC. So once you have acquired the volume of the ovary, what you need to do is you go to the volume analysis, you select SonoAVC, and then you'll just press on right ovary and left ovary, and the machine will automatically outline all the follicles and will color code them, and that prevents any overcounting of the follicles. All the anechoic species are considered as follicle, and that is how the automated calculation is done. The other advantage of SonoAVC is, as I showed you in the demonstration, it not only color codes the follicles, it counts the total numbers, and it gives X, Y, Z diameter, mean diameter, and volume of each and every follicle. You know which follicle is what size, and from the colors, and it also gives a diameter which is most reliable, which is based on the volume. So you would think that why is all this information required? It is because the follicle size of between 2 and 9 millimeters is usually used has a best compromise between the sensitivity and specificity for the diagnosis of polycystic ovarian syndrome. Though the follicle size of between 2 and 5 millimeters is suggested by many studies as being more reliable, and it is said it has higher specificity. It's also been seen in other studies that follicles between 2 and 5 millimeters are clearly more in PCOS patients, whereas there can be an overlap in the number of follicles between 6 and 9 millimeters between PCOS and controls. It is believed that obesity and hyperinsulinemia have a strong role in follicular growth arrest, and therefore patients who have hyperinsulinemia would show more follicles between 2 and 5 millimeters. It is this size of follicles which can also be more correlated with the testosterone and the androstenedione as well as with the ALH serum levels. Even after controlling ALH, follicular number per ovary of between 2 and 5 millimeters still correlated well with the androstenedione and testosterone. And this is again correlating to the pathophysiology of the disease. Suppose I would think that I don't want to count all, or I don't want to see the diameter of all the follicles. I just need to know what are the follicles between 2 and 5 and between 5 and 9. In that case, I can also use another software which is called Sono ABC Antral. When I'm using that, all the follicles in a particular size range would appear same in color, and the follicles in the other size range will appear different in color, and that also can be a very important information. So it depends on what I like to see it as. Do I really want to see the size of every follicle and the color of each of them separately or differently, or do I just want to group them into less than 6 millimeters and more than 6 millimeters? One more important thing, polycystic ovarian morphology has been found to be a better discriminator than the ovarian volume between the polycystic ovarian syndrome and the control women. And what is this morphology that is mentioned in this paper? It is about the stroma. According to the original description of polycystic ovarian syndrome, Sten Leventhal, they've described these ovaries as glistening and solid looking, or a sclerocystic ovary. They've not said it is like a bunch of grapes or there are multiple cystic lesions, meaning that it may have more antral follicles, but it actually has more stroma, and that is also a very important feature. According to another definition, which was again, or I would say another description, which was given by Adams et al. In 1985, they also mentioned that it is presence of more than 10 cysts measuring 2 to 8 millimeters arranged peripherally around a dense core of stroma or scattered through an increased amount of stroma. That means it describes both the peripheral distribution of the follicles as well as the central or the generalized distribution of the follicles, but both have excess stroma. Why is this stromal abundance seen, and why is it one of the very important features? In females with a genetic predisposition to PCOS, high androgen state persists, and androgen is responsible for the recruitment of the follicles, as mentioned earlier, from preantral to antral. But these follicles, under the effect of androgen alone, can only grow to about 6 to 7 millimeters. Beyond that, they require FSH because they develop FSH receptors, and they lose the sensitivity to androgen. These small follicles do secrete estrogen, and therefore higher cumulative estrogen causes a negative feedback to FSH. Estrogen levels may also be higher in these patients due to conversion of excess androgen to estrogen by aromatization. If the estrogen rises to a level which is equal to one mature follicles, which is about 150 picogram per ml, pituitary gets a signal to that the follicle is mature, and therefore there's a complete negative feedback to FSH and a positive feedback to LH. So FSH decreases and the LH starts increasing. When this happens, these follicles were not mature, they were not dominant, and therefore not sensitive to FSH, or cannot, therefore not they cannot grow without FSH. The follicles which have grown to dominance, the follicles which have reached a size beyond 7 millimeters, this will not grow beyond this size if FSH is not available. Instead, they are exposed to LH. Since they are exposed to LH, they undergo atresia, and their granulosa cells, they get converted into theca cells, and it is theca cells which is the main component of stroma. And therefore, whenever there is an ovulation, that's when all the follicles, they undergo atresia, and there's increase in the theca cell population, and therefore increase in the stroma. Even when there is an oligo-ovulatory cycle, that means even when the ovulation has occurred, even then the total number of follicles recruited are much more than what it would be seen in controls. And these follicles, the follicles that have been recruited but have not grown to dominance, will undergo atresia, and therefore even in oligo-ovulatory cycles, these ovaries do show increase in the theca cell population and increased stroma with the disease being manifesting. It is therefore that the stromal abundance is a very, very important feature of the polycystic ovaries. And how does it represent? We know that whenever there is a thicker population of cells, these tissues, they appear hyperechoic. And therefore, as the theca cell population starts increasing, it tries to accommodate itself in some small pockets in the stroma. And therefore, the first sign that you see is patchy increase in the stromal echogenicity in the polycystic ovaries. But when the disease process continues and the theca cell keeps on increasing, that is when gradually the entire stroma becomes hyperechoic. When I say stroma becomes hyperechoic, remember that the stromal echogenicity is always compared to that of the normal myometrium. The normal stroma is isoechoic or mildly hypoechoic to the normal myometrium. But when the echogenicity increases beyond that, it's called increased echogenicity, and it is one of the measures to say there is a stromal abundance. So as the stroma increases, from the patchy increase in stromal echogenicity, there is generalized distribution of follicles with generalized increase in stromal echogenicity. After that, gradually the ovarian size may increase first, or the follicles may be pushed to the periphery, and the other phenomenon follows. That means in some patients there is first increase in the size of the ovaries, and in some patients there is a peripheral distribution of the follicles which occurs first and the other follows. So that explains the different types of 2D appearances of polycystic ovaries. But this is very subjective. A more reliable, a more objective way of calculating the ovarian stromal abundance is assessing the ovarian areas. So you take a longitudinal section of the ovary, you can draw the circumference, and the machine calculates the area for you. An area of 5.5 centimeters square. It has a good sensitivity and specificity for the diagnosis of polycystic ovarian syndrome. Of course, the stromal area would be a more reliable parameter. You can deduct the follicular circumference, follicular areas from the total ovarian area, and you'll get a stromal area, and the stromal area of 4.6 centimeters square is a good cutoff. The ratio of the two may be even more reliable and has 100% sensitivity and specificity for the diagnosis of polycystic ovaries. But it is still a 2D. It is still a 2D parameter for a 3D structure. Three-dimensional ultrasound has a potential to address these points and to improve the sensitivity and specificity of the ultrasound in diagnosis of polycystic ovarian syndrome. And the ovarian volume calculation by 3D ultrasound has been found to be useful over 2D evaluation of ovarian long diameter or the ovarian volume by 2D ultrasound. Along with the ovarian volumes, stromal volumes also can be measured by 3D ultrasound, and this is one of the unique features, because What we are concerned is about the stromal abundance, and it is 3D ultrasound which helps us exactly identify how much is the stroma and how much is the percentage of the stroma if you consider the entire ovarian volume. And this we can see on the live demos also, but you can see it being demonstrated here too. Once the volume of the ovary has been calculated, you can just switch on what is called threshold volume. A pigment will appear which will fill up the anechoic or the hypoechoic areas. You can adjust the threshold so that the pigment fills up only the follicular areas, only the follicular shadows. And when you do that, you get on the result sheet the volume below threshold, which is the volume of the follicles, and volume above threshold, which is the volume of the stroma. And it also tells you how much percentage is the stromal volume as compared to the total ovarian volume. And in all PCO patients, we have observed that the stromal volume is at least 75% of the total ovarian volume. Both the total ovarian volume and the stromal volume and the stromal index during the early follicular phase are significantly high in the patients with polycystic ovarian syndrome. It is this stromal volume can be correlated with the hormonal derangements of which are specific for polycystic ovarian syndrome, which are androstenedione concentration, in the another study with LH and testosterone, and in the third study with the insulin resistance. In one, but this study compares the stromal echogenicity with insulin resistance. In our study, we have compared directly the stromal volume to the insulin levels in the patients with PCOS, and we have found a very strong correlation between the postprandial insulin levels and the stromal volume. That means you can use stromal volume to decide whether patient has insulin resistance or not, and whether this patient would require either insulin sensitizers or you should go for ovarian drilling. 3D ultrasound not only permits improved spatial awareness and volumetric and quantitative vascular assessment, but also provides a more objective tool to examine stromal echogenicity through the assessment of the mean grayness of the ovary. We know that it is increased density of the cells, that means increased more dense tissues that we need to identify from the less dense tissues for the identification of the stromal abundance in PCO patients. This can be done by echogenicity, but when we are doing with echogenicity, we are assessing just a 2D picture. We can do this with a 3D ultrasound, and instead of talking of pixels, which are hyperechoic, we can talk about and then you would switch on what is called volume histogram. When you switch on volume histogram, that is when you would get two informations, especially when you have acquired the volume with power Doppler. The first information that you get about the gray mode is how much is the density of the tissue studies showed that it is not the mean grayness of the entire ovary, but the mean grayness of the stroma, which is definitely higher in PCOS patients as compared to the normal controls, and even the ratio of the stromal mean gray value to the total ovarian mean gray value is higher in PCOS patients, and this can be evaluated only by 3D, and it's a very important piece of information. I did tell you that you get two types of information. The second information that you get is about the vascularity. And why is this vascularity important to us? It has been shown that in the PCOS patients, not only the ovarian stroma is more, also the degree of vascularization is higher. PCOS women showed more stromal vascularization than control, and though on 2D Doppler, where PI and PSV were measured, the difference was not very significant. But when the 3D studies were done, it was definitely seen that the VI value, vascularity index, what do we mean by that? It tells you about the abundance of the flow. I don't think we have time to explain you how it is calculated, but it is enough to know that it tells you about the global vascularity and the global index, and the vascularity flow index, which is the perfusion of the entire volume that you have calculated. So both the things are definitely higher in PCOS patients, and it is this increased vascularity. These values VI, FI, and VFI are again demonstrated on the same volume histogram that we achieved for the mean gray value of the ovary and of the stroma. The observational study has shown that the obese patients have lesser vascularity, and that also can be compared by the VI and the VFI parameters. Counting the multiple follicles in the hyperstimulated ovary is also a difficult task. So we have discussed how to diagnose PCOS, but in PCOS, 3D has another role also, and that is about counting the number of follicles, measuring their size if you have stimulated them for IUIs or IVF, because there are multiple follicles, and that's again where sono-ABC plays a very important role. One last important bit of information is this, that when you have a polycystic ovarian syndrome patient, you've stimulated this patient for ovulation induction for IUI or IVF, and you get multiple follicles, you can use the total ovarian volume to decide whether this patient would have a risk of going into OHSS or not. And if the total ovarian volume is more than 180, both the ovaries together, the chances of getting OHSS is very, very high. But if the total volume is less than 110, no matter what is BMI or what is the number of smaller follicles, the chances of OHSS is extremely, extremely low. That means if you're considering the patients with PCOS, it is very important to use 3D as a investigating modality, because it tells you exactly about the number of follicles. It helps you measure the size correctly. And it also helps you assess the stromal abundance more reliably. And it is these parameters which correlate perfectly with all the hormonal derangements, and also indirectly tell you about the severity of the condition. And looking at the vascularity also helps you decide what should be your treatment strategy for infertility in these cases. Thank you very much.
Thank you, ma'am, for that wonderful presentation on PCOS and how the 3D has added value to it. Now we'll have a live demonstration for evaluating on ovaries by Dr. Sonal, ma'am. Over to you, ma'am.
So we are going to
video shoot चाहिए about machine.
only
So we
for
can do one video shoot also. मेरे को 3 minute देना.
yeah, so we are going to see a young patient, and we're going to work on some of the features to diagnose polycystic ovaries. As we have discussed in the lecture.
Sir, no video shoot. That should come natural, not listen. We will ask you some things about this new lady.
Hello? Yeah, that's great. So it's a midline uterus. We are seeing a lesion there in the uterus. And though it's true that we are seeing this patient for the ovary, we have one more uterine pathology which we can discuss, we can check, we can use the different softwares to assess that. I know it is not a polycystic ovary, but we can still use the vocal as well as sono AVC to find out the size of the follicles, and we'll see how it works. Having located the ovary, what we are going to do is span across. There are only 3 follicles, so actually sono AVC doesn't have a role, but there's no problem. We can still check the modality. We will go to 3D. We will decrease the size of the region of interest or the box to include the ovary and a little bit of area beyond that. I will probably also decrease the depth a little so that I can have a nice big picture. My focal zone is adjusted right at the level of the ovary, and then I would acquire the volume. As I have acquired the volume, the next thing I want to do is I want to assess the size of the ovaries. So I have switched on start volume analysis, and then I would select vocal manual trace. I would select a 30-degree angle, and I will select to work on the A plane. The A plane is this plane. This is B plane, as you can read here. That's the C plane. And then I would press start vocal. I usually select a manual trace. I'm more comfortable with that. But there are other options also, like semi-auto trace and automatic trace. But to me, manual appears to be a little more easier. I have drawn circumference once, and I have then pressed next. You can see the rotation on the C plane. I have started drawing another second trace, and I'm done with that. Moving to the third one. Sorry, that's a little overestimated. And that is the third one. And the fourth one. And the fifth one, and the sixth one. And having done that, when I press done, I have the total volume of the ovary, which is 5.91. And if on that, I accept ROI, and if I put volume histogram, which I'm putting it for the mean gray value, I get the mean gray value of this ovary. I'm not getting any values for the VI, FI, VFI, because these are 3D color Doppler parameters. And since the volume is acquired without the power Doppler, we are not seeing those parameters. We'll work on the 3D power Doppler parameters in a while. Apart from this, you can also use Sono AVC on that. To use Sono AVC, I would prefer that I have a better visualization, a better quality of a 2D image. So I'm going to acquire it once again. I will probably press a bit on the bit. I have to say it's khado parja, full eyes nahi pet. Yeah, acquire. 1 minute. बेटा ना हलाओ, पेट नहीं हलाओ, 1 मिनट पेट नहीं हलाओ. पेट नहीं हिलाओ, खाड़ो पाड़ी दे बेटा, नहीं हाथी नहीं, एमनेम खाड़ो पाड़ दे पेट में, हवा काट नाख पेट मांथी। हाँ, वेरी गुड। चल acquire. Still a lot of I'm not very happy with that. Unless you have a good 2D image, the Sono AVC is not going to be very useful. And otherwise also we have acquired one more volume with of the ovaries, and we'll show the Sono AVC on that, or we will acquire one more. Since this is a uterine lesion, you know it's a fibroid, you can see the edge shadows and the fen shadows both. If you put on a Doppler, you will see a nice peripheral vascularity surrounding. And that is also where you can, so it's not just the ovaries, you can also use your Sono AVC there. You can acquire a volume with power Doppler. And you can beautifully appreciate the vascularity there in the 3D picture. You can increase the, so you can increase the threshold of HD flow, and you can get beautiful idea about the peripheral vascularity of the fibroid. Not just that, you can also go and acquire the 3D volume of the entire uterus, and you can find out what is the impact of that fibroid on the endometrium. We'll just go to sub 3D and we will take the up down. When we do an up down, you will not see the fibroid and the endometrial cavity in the same plane, because you'll only see what is crossing the green line. But to see that fibroid, you can use a reverse viewing direction. And when you do that, and you are using a transparent mode associated with the surface mode, which is minimum. So that's when you would be able to identify both the endometrium and the fibroid. So you're seeing the fibroid impacting here on the endometrium. And you can also, on the other side, if you don't want to see it like that, you can come back to your routine rendering mode, and then you can also cut through to see the fibroid and its relationship to the endometrium. So that's how it works. So it does touch the endometrium, but it is not creating a big impact on it. So that is how you can use 3D for the assessment of your uterine lesions, and that's how you would use the vocal. Thank you, Ben. Yeah, so we're going to see the next patient. And in the meantime, I would like to tell you that it is very, very essential that to get good 3D images, the primary necessity is a good 2D image. So you cannot get good 3Ds if your 2Ds are not good. And therefore, the first point is to optimize your 2D images to the best. The focal zone and the depth properly, and there looks like this is the next patient. We are seeing the uterus in the midline. There is a very non-uniform endometrium. You are seeing some hyper-echogenicities also in the endometrium. There may be an endometrial pathology likely, but before we go to that, we can actually acquire a volume for that and store it. When you have subtle changes in echogenicity like this, it is VCIA that we used in one of the previous patients, which is very, very useful. Apart from that, you can also use OmniView. And we have stored that, but we can go to VCIA, and that gives better idea about the non-uniformity. We would probably decrease the angle, and that would improve the frame rate for the 4D. So yes, that shows definite irregularity. There's a possibility there might be a polyp there inside. We can, or there can, I mean, I also doubt some sort of fibrotic stents here, but since the endometrium is quite thick, it is being less likely. We can switch on the Doppler and we can check if there are polyps. Polyps, as we know, have single feeding vessels. There is no definite vascularity appreciated. Sometimes you may see a better vascularity on power Doppler instead of on HD flow, but there is no definite indication where you can use power and where you can use HD. It is quite variable as to what you would see. Of course, if I'm seeing it closely, I'm seeing one lesion here, another lesion is here, and probably there is one more lesion which is right in the center. Period, no? Okay. So it looks like mid-cycle, and so we have acquired the volume and we can work further on that. In the meanwhile, we are going to go to the follicles and then ovary. ઓશીપું કાઢી નાખો અને સેજ નીચાઓ અહીંયાથી પગ પોળા કરો બસ. And we are seeing the ovary much better. We don't want this big an angle. We are going to decrease the depth also. We can, if we wish to increase the contrast a bit, set the focal zone, and then we can switch on the Dopplers. We can switch on the Dopplers to check the vascularity in the ovary. You can decrease the gains a little because there's a lot of spill outside, or you can also use HD flow. Rotate the probe gently, span across, and look for the vascularity in the ovary. With your steady hand, you can switch on the 3D. Usually we increase the gains a bit to get, before we acquire a 3D. બંને હાથ પેટ ઉપર મૂકી દો અને હમણાં 2 મિનિટ માટે શ્વાસ નહીં લેતા. ઓકે, बिल्कुल श्वास नहीं लेता प्लीज. Low. We are going to store this volume and we'll work on it a little later. Going on to the other side, we have an ovary which is a bit deep. We have it is about a mid-cycle. We are seeing a corpus luteum in there, and corpus luteum usually shows much better flow if it is active, and you can see a nice ring of color around, and usually has a low resistance flow, though this is not the time when you would usually want to do the rest of the assessment to assess the ovarian vascularity, but just for the sake of doing that exercise and knowing how the function works, we will acquire a volume for that too. Since this acquisition is with Doppler, it is usually a little slower acquisition, and therefore it is essential that you request the patient not to breathe during that period. I know we have acquired the volume of this uterus for earlier also in this during this demo, but I'm just checking, there's no vascularity inside, which is quite common if it is a closed, if it's a fresh rupture. We will also take a 3D of this endometrium to assess the volume of the endometrium. So earlier I had taken the volume of the entire uterus, and now I'm concentrating only on the endometrium. We will work on this volumes that we have stored after the lecture, because then we'll know what we are going to discuss and why are we doing this assessment.
Thank you, ma'am, for that wonderful presentation and the demonstration of the vocal. Now we'll have a presentation by Dr. Sonal for the role of 3D in follicular and endometrial tracking. Over to you, ma'am. Hi, I request all the participants to post your questions in the chat box. Will be answered at the end of the sections. Thank you.
The next session is on the role of 3D in follicular and endometrial tracking. Infertility, we know, is becoming a more common problem than ever before, and the common treatments are IVF and IUI, and both require ovulation induction, and therefore follicular and endometrial monitoring is a very, very important part of the practice for all infertility specialists and as well as gynecologists. Doppler plays a very important role in the cycle because The hormonal changes reflect almost instantaneously as vascular changes and then as morphological changes in the uterus and the ovaries. An ultrasound can be useful at almost every step of the ovulation induction or the treatment cycle, starting from the baseline scan or where you want to decide the stimulation protocol to the assessment of the maturity of the follicle, to the assessment of the endometrial receptivity, and finally during the luteal phase assessment. If I say that I need to do a scan when I want to start stimulation protocol, the main concern before I start the stimulation protocol is that how many follicles I will get at the end of stimulation. And the second important query is how much dose of gonadotrophins, if I'm giving, I will require to stimulate this patient. Of course, it is true that when you are giving oral ovulogents like clomiphene citrate and letrozole, that's when you do not actually require much assessment of the ovarian reserve, because this you are giving as minimal stimulation and you only expect 1 or 2 follicles to mature. But when you are giving gonadotrophins, it is called controlled ovarian hyperstimulation, and it is in these cases that you definitely want more follicles to grow, and therefore you need to assess how many follicles you are likely to get. How many follicles you are likely to get? This assessment is done by 2 things. 1, the number of antral follicles, and 2, the ovarian volume. And this is called the assessment of the ovarian reserve. Whereas how much dose of gonadotrophins you're going to require can be decided by the amount of flow in the ovaries and the RI and the PSV if we are considering the 2D Dopplers, and FI if I'm considering the 3D power Doppler. FI, I didn't talk about this parameter in the earlier presentation. Flow index tells you about the average intensity of the flow in the decided or the defined volume. So if I want to decide the ovarian reserve and the ovarian response, this scan must be done on day 2 or 3 of the cycle. And this is called a baseline scan, because on the baseline scan, you usually expect the ovarian steroids, the estrogen and progesterone, to be at absolute baseline. The ovarian volume, as we have discussed earlier also during the presentation on PCO, can be measured either by 3 longest orthogonal diameters on the 2D ultrasound, but it is 3D ultrasound done by vocal, which may be considered a more reliable parameter. We know that if the ovarian volume is lesser than 3 cc, it is a high chance that if the patient is taken for IVF, there is a possibility of resulting into cancellation of the cycle for poor response. And in these cases, you would not prefer to take these patients for IVF, or you will be given very high doses of gonadotrophins. But when we're talking about the 3D ultrasound, volume is not very important parameter to decide the ovarian reserve, not as sensitive as a antral follicle count. A meta-analysis has shown that AFC is a better predictor for poor response compared to the ovarian volume. And you have seen this slide earlier also. The number of antral follicles can be counted by 2D, as you know, and as we have already discussed, if the number of antral follicles is not more than 12 to 15, whether you use 2D or 3D, both are equally reliable. But if the number of antral follicles are more and you want to be very precise, which is truly required when it's a PCO patients, because when you stimulate PCO patients, and your dose calculation is not correct, there's a very high chance of these patients going into a complication called ovarian hyperstimulation syndrome, which is truly a nightmare for all the infertility specialists because it's often life-threatening. And in all these cases, it is more advisable to use sono-AVC to decide what is the number of antral follicles. The number of follicles larger than 12 millimeters on the day of oocyte retrieval correlated significantly with the antral follicle count counted by 3D ultrasound rather than by the 2D ultrasound. And you have already seen this sheet, this result sheet, this report sheet for the sono-AVC with all the 3 diameters, mean diameters, and the volume. Sono-AVC, according to the studies, measured less number of follicles on AFC, though it took significantly less time to measure the size and record the number of the antral follicles. And this less number were measured because it doesn't overcount the number of follicles. And this is a very, very important function and a very important reason why you should use 3D to decide the number of antral follicles. Of course, you will require post-processing, and we will see that in the stored volumes in the next demo session. Post-processing can be used for the follicles that are missed out on automated counting. An additional advantage is that the size of the follicles can also be seen, and that is a very important clue, not only for deciding the biochemical parameters of the PCO, but also to decide the stimulation protocol and also to decide when to increase the dose if the patient does not show response to the stimulation. 3D is also important, especially when there are multiple follicles, because the total number of antral follicles counted by inversion mode, you are likely to get 60% of these follicles as grown-up follicles. And when I'm talking about inversion mode, this is a mode where all the fluid-filled structures are seen as solid structures on the render mode. Why is this important? This is a very important mode. And why is this important is because our eyes are trained to identify solid, tiny areas more easily and more precisely as compared to the fluid-filled areas, in which you can recognize in this image also. And sono-AVC is nothing but an extension of the inversion mode to color coding and the size of the follicles. Why am I repeating over and over again about the size of the antral follicles? Is because, as we had discussed in the previous presentation also, it is the follicle size of between 2 and 6 millimeters which grow under the effect of androgen. But as the follicles, they reach the size of 6 to 7 millimeters, they develop FSH receptors, and it's only after that that they would respond to the FSH stimulation. Now, if I'm doing an eye-to-eye cycle where I expect only 2 or 3 follicles to grow, I do not want multifollicular development. If I start gonadotrophins, only once I see one follicle which has reached to an FSH sensitive stage, 1 or 2 follicles, and then I'm going to start FSH. Not only I'm going to control the number of FSH ampules that will be used, but only those follicles which have reached the FSH sensitive stage will grow further. Instead, if I start FSH earlier, not only that I'm going to waste on the FSH ampules for the first 2 or 3 days till the follicles reach an FSH sensitive stage. The another disadvantage is that when I'm giving that FSH, the blood levels of FSH increase, and more follicles may grow because all the follicles would get sensitized to FSH almost at the same time. The FSH level is also high, and there may be a multifollicular development. So when you're doing an IUI cycle stimulation, it is essential that you may wait for 1 or 2 days before you start gonadotrophins if all the follicles are smaller than or equal to 6 millimeters. In case of IVF cycles also, this is a very important bit of information, because though it is a fact that in all IVF patients we start stimulation on day 2, if it's a PCO patient, in this patients the follicular population between 2 and 6 millimeters is much more than between 6 and 9. And it often happens that as a routine, when you assess these patients on 5th or 6th day of the stimulation, the follicles might have not reached a size of 10. This is not because the ovary is not responding. This is because the follicles, they reached the sensitive stage a day or 2 later. And therefore, in this cases, you increase the dose a day or 2 later. If you increase the dose before that, earlier, there's a higher chance of these patients going into ovarian hyperstimulation syndrome. The second important thing is the assessment of the ovarian stromal flow, and we know that the stromal flow in the early follicular phase is related to the subsequent ovarian response. Total number of antral follicles achieve the best predictive value, followed by ovarian stromal FI, and then the stromal area and the total ovarian volume. So after the antral follicle counts, it is the stromal flow which is the most important parameter. And if the FI is less than 11, the patient may be a poor responder. Between 11 and 14, she's a good responder. More than 15, she has a higher risk of OHSS, according to the study of Professor Kupasik. And this VI-FI, VFI, we know if we want to, we can assess once again. We can definitely do it once we have acquired the volume with the 3D power Doppler, followed by vocal, and then pressing on what is called volume histogram. This VI-FI and VFI parameters are important. There are several studies which have shown that VI-FI and VFI of the ovary is significantly related to the ovarian response to stimulation. Why is that so? Is because if you look at the logical explanation for the same, if the blood flow to the ovary is more, then when you load gonadotrophins into the patient's system, because more blood is flowing into the ovary, more percentage of this gonadotrophins will flow into the ovary, and therefore the total dose required for the patient to stimulate her ovaries to produce follicles is less. And therefore, more blood flows, that means patient requires lesser dose, and therefore patient is a good responder. Whereas if the flow to the ovary is less, that is when less percentage of total drugs loaded into the patient's system will flow into the ovary, and therefore to deliver sufficient amount of drugs to the ovary to stimulate or to allow the growth of the follicles, the total amount of gonadotrophins to be delivered to the patient is going to be much more, and therefore if the ovarian flow is less, patient is a poor responder. It has been shown that the vascularity in the ovary is less in the patients who are more than 41 years of age, and we all know that these are the patients who are labeled as poor responders. That means they require higher doses, and that is because their vascularity is low. In patients with endometriosis also, it is usually expected to have a poor response. Significantly lower 3D vascularity indices for the ovarian stroma has been found in the endometriosis group without decrease in the ovarian volume. And it has been proved that quantification of the ovarian stromal flow by 3D power Doppler ultrasound in women with endometriosis may provide an important prognostic indicator in those undergoing IVF. That means that generally patients with endometriosis has lesser flow, but if the flow is more in the patients with endometriosis in the ovary, then they may still respond better. AFC, ovarian volume, and ovarian 3D power Doppler flow indices did not significantly change after a short-term treatment of GnRH agonist for pituitary downregulation. That means you can use the same protocols, the same values for the IUI, for IVF, for IVF agonist as well as antagonist cycles. That means you use the assessment, you use 3D for the assessment of the ovarian volume for the antral follicles, and also for the 3D power Doppler, VIFI, VFI, to decide the stimulation protocol to get the best assessment, best judgment on the correct stimulation protocol. Then coming to the pre-ovulatory process, we know that follicle which is larger than 10 millimeter in volume is a dominant follicle, grows at a rate of 2 to 3 millimeter per day. We all know that ovulation will occur when the size is between 18 and 24 millimeters. Two important parameters on 2D ultrasound, which is a hypoechoic halo surrounding the follicle as shown by the gray arrow, and the cumulus as shown by the black arrow, which both appear about 24 to 36 hours before ovulation, and it is about 6 to 10 hours before ovulation that you'll also get some low-level internal echoes parallel to the follicular wall, which is suggestive of an impending ovulation. The follicle size is measured in the same way as we discussed for the ovarian size. Because it's a cystic structure, the measurements are taken inner to inner. The follicular size is always to be described as a single diameter, which is a mean of these three diameters, and not as A into B into C. But very interestingly, when you have an IVF stimulation, you have multiple follicles. And when you have multiple follicles, that is when it is very, very difficult to find out the exact diameters of the follicles. Number one, it's very time consuming to measure three diameters for all these follicles. And number two, because of multiple follicles, they're not round. So even if you take mean of three diameters, it's not going to be the correct measurement. And therefore, in these cases, follicular volume is a very important parameter to decide the time of trigger. And when measured by 3D, it is much more reliable than when you measure it by 2D. Sono-AVC, as we know, is a method of choice. It is very accurate and efficient way to measure the ovarian follicles. Sono-AVC was suggested to help establish new criteria for the timing of trigger administration based on the follicular volume estimation rather than just the follicular diameter. Why is important? Why is it important? Yes, it is true that follicles of between 3 and 7 millimeters, they usually match the size of 18 to 24 millimeters. But it has been seen that all the follicles up to 1 cc in volume would definitely give you fertilizable ova. Not only that, in one of our very recent studies, we have found that even the follicles up to 0.6 cc are likely to give you fertilizable ova. And therefore, especially when the yield of the ova are less, you must pick up all the follicles up to 0.6 cc in volume. Cumulus, as I told you, can be seen in about 24 to 36 hours before the ovulation on 2D ultrasound. But since it's a very tiny solid structure, you need a proper optimization of the image and zooming, and of course, a very careful spanning across the entire follicle to find it out. And therefore, it has been documented that in 2D, when you use 2D ultrasound, you'll see the cumulus only in about say 35 to 40% of mature follicles, but it's much more easier and much more well demonstrated on 3D ultrasound, as you can see here. And it is one of the surest signs to tell you this follicle contains a fertilizable ovum. It is described in one of the studies that cumulus is present in the follicles larger than 15 millimeter. And why is cumulus important to us? The cumulus is important to us because especially in the cases where you have repeated failures of IUI, if you're not seeing the cumulus, that means it's likely that these patients may have anovulatory cycles, one. Second is when you're doing IVF, when you have a poor reserve patient where you only have developed 2-3 follicles on both the sides. If you've seen a cumulus, you aspirate the follicle, you don't get the ovum. It is in these cases that flushing and aspiration does improve the yield of the ova, and this is the role of cumulus in your practice. Coming to the vascularity part of it. It is as early as about 8th day of the cycle that the blood vessels start developing around the follicles, and the fall in the perifollicular RI, resistance index, occurs about 48 hours before the ovulation. And when the RI reaches 0.48 and the PSV reaches 10 centimeters per second and the vascularity covers at least about 2/3, preferably 3/4 of the circumference of the follicle, that's when the follicle is called to be functionally mature. That's when the surge will start. But if I say I have to see whether the follicle covers, whether the vascularity covers 2/3 or 3/4 of the circumference or not, it is always 3D, which helps me better to know how much is the vascularity when I'm using 3D powered Doppler with rendering into the color or the glass body mode. And this is important because if the vascularity to the follicles is less, the ovum inside is hypoxic, and there's a very high chance of these follicles going into, developing into embryos with chromosomal abnormalities. Even when you go not only for the subjective but for the quantitative assessment, in our studies we have found that when the VI of the follicle is between 6 and 20 and when the FI is more than 35, there's a higher chance of these patients getting pregnant and resulting into a live birth as compared to when the values were lower, in spite of the fact that on 2D Dopplers the parameters did meet. So apart from the follicle, which is about 16 to 18 millimeters, the vascularity covers 2/3, preferably 3/4 of the circumference, RI less than 0.5 and the PSV more than 10. If you add these parameters, VI between 6 and 20 and FI more than 35 and the cumulus, you may definitely improve your pregnancy rates significantly. Endometrial measurement is done correctly when the endometrium is right in the center of the image and the sound beam hits the endometrium perpendicularly, and it's measured perpendicular to the central line from outer margin to the outer margin. But endometrial thickness may not be as reliable a parameter as endometrial volume, especially when the uterus shape is not normal, 1. 2, when the uterus is either too small or too large, and it is in these cases that you can use vocal. After acquisition of the 3D volume, we are going to do this on the live demo also, so I will prefer to skip this, but just telling you a few very important points. You must put your line, vocal line, where the endometrium appears the broadest, and the volume is measured right up to the internal os. 2 important things. Third thing is endometrium is not a round or an ellipse structure, and therefore to accurately measure the endometrial volume, you must use the step of rotation as 9 degree and not as 30 degree. What more is that especially when you have very thin endometria with a long uterus, or you have good endometrial thickness with a short uterus, it is in these 2 cases that you definitely need to check the volume of the endometrium, because when the volumes are less than 2 cc, the chances of implantation are less than 1 cc, there's almost 0 implantation rate. But when they are 3 cc or more, the chances of implantation are much, much better. Endometrial volume by 3D ultrasound volume calculation may help to correlate the cycle outcome with quantitative parameters rather than the endometrial thickness. And for the endometrial volume, the inter-cc definition of the internal os and the inter-observer variation was 0.82% and intra-cc was 0.9. The chief source of error was the definition of the endometrial margin. So as I told you, it's very, very essential that you have a very good 2D image to do your 3D calculations as well as 3D rendering the best. There are different studies which have shown that endometrial volume is much more important. The endometrial vascularity is equally important, and it should reach the inner layers, must have an RI of less than 0.6. If it is not there, there's a high chance of implantation failure, or even if the implantation occurs, there's a high chance of abortion. These parameters are important for IUI as well as for fresh IVF cycles. Before giving the trigger, when you're doing frozen cycles, these parameters must be matched before you start progesterone. And it is 3D ultrasound, which gives much better idea about the vascularity, whether it's reaching the inner zones or not. You can see in that clip beautifully the vessels reaching the innermost layer of the endometrium, and this would this would stand for an excellent vascularity and excellent receptivity of the endometrium. And there are several studies which have measured VI, FI, and VFI parameters. They have given the cutoffs to tell you that the endometrial receptivity can be best assessed by the 3D power Dopplers. For our study, endometrial FI of more than 40 and endometrial VFI of more than 20 have given us excellent results. If I'm talking to you about the recent study of ours with frozen transfers, in all those cases where we confirmed that the vascularity was present in zone 3, the ongoing pregnancy rate was as high as 85%. The endometrial, so if I sum up the parameters, endometrial minimum 6 millimeter, preferably 8 millimeters, 8 to 10 millimeters vascularity reaching zone 3 and 4, that means the inner layer of the endometrium, RI less than 0.6, PI, uterine artery PI less than 3.2, and the endometrial volume of at least 2.5 to 3 cc, PI more than 20, and VFI more than 5 are very essential parameters. It is 3D ultrasound, which also helps to decide what would be the type of trigger. The type of trigger is very, very important to us, because when you do an IVF stimulation, multiple follicles, there's a high risk of OHSS, and this can be prevented if you select the correct trigger. There was a strong trend towards agonist trigger for all, but agonist trigger results into a luteal phase defect and failure of pregnancy. In these cases, to rescue the luteal phase, you can give a dual trigger. That means you add to the agonist trigger, you can add 1500 HG. But this also has a limitation. If you have more follicles of more than 25 follicles of larger than 11 millimeter on the day of trigger, it's not advisable to give even 1500 HCG. According to another study, if you have more than 18 follicles between 10 and 14 millimeters, apart from the larger follicles, even then you don't give HCG at all. And this is how you can give only agonist trigger and prevent the risk of OHSS. And this can be well judged by your Sono AVC. So Sono AVC is a very important tool, especially for all IVF specialists, I would say, and even 3D and 3D power Doppler. It is by 3D that you can also assess the point of maximum implantation, and you can do your transfers there. You draw a line parallel to both the cornu where these two lines intersect. This is a point of maximum implantation potential. You measure the distance from this intersecting point to the external os, and it is only that length of the cannula that you allow to enter beyond the external os and do the transfers there. You can get excellent results. 3D and 3D power Doppler significantly adds to the precision of decision making in the follicular and endometrial monitoring for both IUI and IVF cycles. And thank you very much with that for a very patient hearing.
That was a really wonderful presentation, ma'am, and the 3D images were amazing. And now we'll have a live demonstration on to you, ma'am.
Yes, so there are just 2 or 3 things. I know we are late. There are 2 or 3 things that we wanted to discuss and I wanted to show you. And the first thing is vocal. I've selected volume analysis, vocal, and start vocal. As we start that, this is the ovary with the corpus luteum, as you know, but I'm just trying to show you how we can assess the vascularity. And I'm going to be a little quicker, maybe a little more inaccurate, but if it's about showing you the method. And once we have done that vocal, we will accept ROI. Once we accept ROI, then we will just go to volume histogram. And as I told you, it will show you the VIFI and VFI parameters. Not only the VIFI and VFI parameters, if you just want a subjective idea about the vascularity, you can go to subvocal and you can select color, and that shows you beautiful vascularity of the corpus luteum that we saw. And of course, the vascularity in the stroma is not that much because we know this is a luteal phase. So or you can also use a glass body, and you can see the 2D as well as the 3D picture of that. So that's how you would do the volume histogram. Quickly going to that rendering. And that is where you would select the up-down mode, plan the line on the endometrium, and you can increase the breadth on the B. You can probably decrease the magnification a bit so that you can see even the fundus of the uterus. And you are seeing those lesions that we saw on those solid lesions in the endometrium very well in the fundal area. If it is about the shape of the uterus, then you can, this itself shows the shape well. You can also use the HD live mode to show the shape of the uterus. There is one more way that you can do it, where you can use Magic Cut to show the shape. And so that is how if you want to use Magic Cut, you can use define Magic Cut, and you can say I will trace outside, and you can cut a few layers, and that will very beautifully demonstrate the uterine shape. So there's a lot more that you can do with 3D. The time is never sufficient, but thank you very much for a patient hearing, and hope to see you soon sometime again.
Thank you, ma'am. That was a wonderful demonstration of the uterus and the vocal. I invite Dr. Sonal and Dr. Ajay sir to have the question and answer section. Please, sir. Hello, ma'am. Hello, sir. So the first question is, Sonu AVC is always to be used for stimulated ovary?
No, it is to be used for baseline scan also, as well as for the stimulated ovaries too. You can use Sono AVC for any cystic areas. That means even if there's a hydrosalpinx, you want to calculate the volume, you can use it. But yeah, for all stimulated ovaries and or for all PCO antral follicle counts, I would always do Sono AVC. It's a very time saving and quite accurate.
It's very important in AFC count.
Yes, that's right.
For getting an accurate AFC count, this is very useful.
Yes, that's right.
Thank you, sir. So the next question, can we see coronal plane of diadelphous uterus with the help of 3D tool?
Yes, of course. Why not? If you are saying, I know what the question means. The question means that the two corpora are very far apart and there is a limitation to the volume angle of 120. I will give you a clue for all biconvex as well as diadelphous uterus, acquire a volume on the transverse section and acquire a separate volume for the cervix, and that serves.
Especially biconvex, it's very comfortable and very easy to do it with transvaginal. But for diadelphous, if both the corpora are very far away,
but even
it does not, even if you use more than 120 angle.
No, so you cannot use that. What I mean to say is when you're seeing in transverse, even vaginal works. So he's very right that abdominal is much more comfortable because then the view doesn't need to be changed, but he's very, very right. But even vaginal, if you are using a transverse section and transverse acquisition, it works.
Thank you, ma'am. And the next question is, can we measure stromal versus ovarian volume?
Stromal was, can you measure?
Stromal versus ovarian volume.
Ovarian stromal vessel volume you cannot measure. For the vessel, you have to measure VI, FI, VFI, right? You cannot measure the volume of the vessels, but indirectly, if you think when you are measuring the VI, which is the abundance of the flow, you are actually measuring the total volume of the vessels.
So the next question, and this is the last one. What is the percentage of difference in volume of ovary taken in 2D versus 3D?
There are a few studies actually, but I've not quoted them here. But it depends more on the shape of the ovary. If the shape of the ovary is ellipse or round, the difference is not very significant. But when they are not rounded, they are a little longish. That's when the difference is more, according to my experience. So what do you say?
She's saying, right. What she says is
okay. So that answers all our questions. So thank you, Dr. Sonal, and thank you, Dr. Ajay V Valia, sir. That was really nice having wonderful presentations, and the live workshop was really good. Working on the vocals and solo ABC, that was really good. Thank you so much. Thank you for the time.
Thank you. you.